So it's now a pleasure to introduce our last speaker, who is José Tony Carugno. He's a board certified in obstetrics and gynecology, training in advanced gynecological surgery at Florida in a hospital in Orlando. And he's an associate professor in reproductive sciences at Miami. So please, Tony, tell us about how surgery works. Thank you.
Thank you so much. And I'm so happy that they left me last because you guys made my life so easy now. I'm really thrilled to have a chance to speak about one of the two hysteroscopic procedures that I get more pleasure doing, which is fixing a dysmorphic uterus. The other procedure is doing an isthmosis repair. No conflict. So I have given the task in 10 minutes to prove to you why surgery works. And if you pay attention, you'll see why. I'm going to start to saying this. People will generally accept facts as truth only if the facts agree with what they already believe. Right? So how do we come to choose what do we believe? Well, we go to evidence-based medicine, right? We know start with expert opinion, but we really got to make our evidence at the top with systematic review of well-conducted randomized controlled trial. We all know that. But we also know that this is what we read. This is what's in our literature, right? That's how we base the evidence that we read. So I'll tell you what evidence-based medicine is. Well, I'll tell you what evidence-based medicine is not. What is not, it's a cookbook, right? If you really want to practice evidence-based medicine, you need to put together three things. One is what you read on the evidence, right? The external evidence. But you have to combine that with your individual clinical experience and with patient choice. So when you put those three things together, what you read, your own experience, and the patient choice, then you can make the decision what's best for the patient. We don't need a randomized controlled trial to prove the thing works, right? The classic study. There is no study randomized people jumping on a plane with or without a parachute to see which group did better. But we do believe the parachute work, right? But we also know that we can twist the study and do whatever we want. We want to prove the parachute. We can make people jump from the plane, but the plane is not in the air. The plane is on the ground. And we can do the study. And then we have statistics. We all know that if we twist the data good enough, we can make anything look statistically significant. So for the purpose of this talk, we all agree that a dysmorphic uterus, it's a uterus that looks normal on the outside and have thick uterine wall that make a very narrow cavity that sometimes looks like a T-shape. But this is the problem, right? The problem is those bands of muscles that are in the middle of the uterus that give this tubular appearance of the uterine cavity. So who is the patient with a dysmorphic uterus? It's that mid-30s who's been on OCP for a long, long time. And then when you ask her, how are your periods? She will tell you, well, doc, my periods are very regular, but they really last 2-3 days, and it's very scant. The day that I bleed most, I change the pad 2-3 times an entire day. And then they have infertility, recurrent pregnancy loss, and the other problems. But why? Why do they have those poor reproductive outcomes? It's because they have poor endometrial quality. It's the intracavitary volume that is too small. It's that muscle that contracts. We don't really know. There is a lot of questions without an answer in this pathology. We all know the DES, right? But we also know that the youngest patient who was exposed to DES is my age now, so fertility is not a problem for them. All of a sudden, from the new classification, the SRM, dysmorphic uterus disappeared. It's no longer there. We do have it on the European classification, but we don't even know what's normal. I want to give a thumbs up to Professor Gregolet, who in the last expert meeting presented this study where he's looking at what is normal. He's measuring normal uterus so we can establish what normal is, and then we can say what's abnormal. A brilliant mind, Professor Costas, made it simple. Just, it's wide on top, narrow in the bottom, just measure the ratio. But then the expert came, right? And they gave a very, academic, they measure angles and, the exact 7 millimeters and give a more academic definition of what a T-shaped uterus is. As I already said, Professor Alonso and I published the Rule of 10. It was a brilliant personal observation of Luis. He just looked, listen, if you do the 10 millimeter thing, a patient with dysmorphic uterus, the diameter in the middle of the uterus is less than 10 millimeters. But to make things a little bit harder, the uterus is a dynamic structure. We know that the uterus stretches from birth until the age of 40 to 72 millimeters, and then shrinks back to 42 millimeters at age 80. And also, if the patients conceive, it becomes also wider. To make things more complicated, it seems like this T-shaped thing may be a transient condition. Maybe it's just uterine contractions that makes the uterus look like a T-shape at the time that you're scanning. And this publication here is saying, keep calm, just re-scan, wait a little bit, maybe it's a contraction, it's not really a T-shaped uterus, it's something that you're seeing that is not really there. So, but in the meantime, if we keep discussing here our academic thing, this woman, she's gonna be in my office on Monday. What should I do with her? Then do surgery. I have a simple procedure that will make her narrow cavity look more like a normal cavity. And we already presented the evidence. I'm not gonna continue it, but our old chairman of this Congress presented his experience. 60 patients, no babies before the procedure, after the procedure, clinical pregnancy rate, 90%, 35% conceive spontaneously. And another interesting thing that he published is there were no surgical complications during this procedure, and he took biopsy of that area that he removed, normal myometrium, right? It's not fibrotic, it's just normal myometrium. Questi belli ragazzi here, they did a European multi-center study, over 200 patients, same thing. And I want to bring the attention of this, clinical pregnancy rate, 71% after the procedure of the patient who had primary infertility, 77% on those with recurrent spontaneous miscarriage. But I want to bring your attention to the bottom part. Mode of conception, spontaneously, almost half, 50% of the patient after the procedure, they just conceived spontaneously. We have the systematic review. I'm just gonna say that either pregnancy rate, live birth rate, and all the things that we saw, it's either improved or not reported. Look at all those studies. We did our all systematic review that actually became a CME article. Same results. We also did a SWOT analysis. What did the SWOT analysis know? What were the strengths of what's out there on the literature? Well, the strength is we have a high pregnancy rate and a high birth rate after the procedure. What are the weaknesses? The data, it doesn't come from randomized controlled trials. So this is a slide that resumes all what I just said. So you have a patient that before the procedure has 0 pregnancy rate, 0 live birth, 0 spontaneous pregnancy. You do the procedure, and those are the numbers that you have after. 70% pregnancy rate, 45% live birth rate. Spontaneous pregnancy rate, 50%, half of the patients. Complication, negligible. Cost, really minimal of doing the procedure. So, but why? What is the reason of this such good outcome? Is that we restore anatomy? Is that just to modify the physiology of the uterus because now we have a different shape of the uterine cavity? It's just a scratching effect? I think it's an act of God. It's also a possibility. But one thing I know, it's a lucrative condition. We make money when we do the procedure, right? When this paper gets published, I got so mad, you have no idea. I started calling the musketeers, right? The kings. I say, oh my God, did you receive that paper? So they published this. Clinical decisions should always be based on methodological rigorous studies, yes, such as randomized controlled trials. And to date, the effectiveness and safety of metroplasty for tip-shaped uterus has not been evaluated in a randomized controlled trial. But they went on and said this. Advocating for these procedures, it's supported by industry, not because they're helpful, but because they are lucrative. Statements like this in writing should be condemned by all three kingdoms. When the patients read this, they're not going to say, oh, the hysteroscopist wants to make money out of me, but the sonographer was the best for me. No, they lose confidence in all of us. And then what I was thinking is, they say it's a lucrative condition. If I think well, I think it's the opposite. We lose money by doing this procedure. Because if I do this procedure and 50% of the patients conceive spontaneously, they don't come to us anymore. They don't need us anymore. We're losing money, actually, by making them pregnant. I know there is lack of scientific evidence. We have many, many questions that don't have an answer. I know that. But do we really need a randomized controlled trial to prove this? Is it doable? Do you really believe that it's fair or ethical to randomize a patient to the do-nothing group? Not so sure. So, in the meantime, what should I do with her? She's going to be in my office on Monday. So, I think that until further data is provided, performing hysteroscopic metroplasty is the best therapeutic option to improve reproductive outcomes in patients with dysmorphic uteri. Listen, the randomized controlled trial that we all want is very unlikely to happen. What we currently have, we have low quality data that support the surgical intervention. We have a known low-risk surgical procedure, an inexpensive procedure that works really well to treat it. So it is my opinion that hysteroscopic metroplasty should be offered to infertile women with dysmorphic uterus in a shared decision-making model, meaning you present the data to the patient and let her decide if she wants it or not. In conclusion, if we hide behind the rigorous rule of evidence-based medicine, it could be considered scientifically sound, but will tie the hand of many skilled, well-intentioned hysteroscopists and will prevent us to fulfill the #1 objective of our kingdom, which is help our infertile patients to conceive. And with that, I want to thank the committee for inviting me to be in this talk, and I want to congratulate the Heart to STEAM for such a great meeting. Thank you so much.